approach of ectopic pregnancy. First of all, we start with the history. Okay, the history. Actually, we have a triage of ectopic pregnancy with three important symptoms. The first symptom to appear is bleeding. And the cause of bleeding is in ectopic pregnancy we don't have as big as much sac. We don't have a sac that big enough to secrete the levels of hormone that are enough to support pregnancy. Okay, so we have a small sac, not like a normal sac in pregnancy. In normal pregnancy, okay, we have a small sac that is not able to secrete normal hormones levels to support the pregnancy, so we have a bleeding. Okay, this is the first symptom to appear. The second one is abdominal pain. And this is important symptom also. Okay, so bleeding, abdominal pain, and then amenorrhea. Okay, amenorrhea, because it is a pregnancy. An important point about bleeding: most of bleeding from ectopic pregnancy is mild bleeding. Okay, so streaks of blood. And sometimes we have huge or heavy bleeding. Okay, rarely we have heavy bleeding, but most of the time we have streaks of blood. In miscarriage, to differentiate between ectopic pregnancy and miscarriage, in miscarriage the pain precedes bleeding. Okay, in ectopic pregnancy bleeding happens first and then pain. In miscarriage, pain then bleeding. Okay, this is just a light to show you. After history, we move to physical examination. And okay, I just forgot to say that in history of ectopic pregnancy we may have a case of hemodynamically instability. Okay, because of a huge bleeding we may have tachycardia, hypotension, and so on and so forth. Okay, so it's an important point in history of ectopic pregnancy. Now let's move to physical examination. First of all, we have to start with the general look and vital signs. Okay, and to take care of vital signs is the blood pressure. As we said, we may have hypotension. Now, and after that, we move to abdominal examination. We may have abdominal rigidity. If we have a ruptured ectopic pregnancy, we may have guarding and rigidity. Okay, the most important and specific physical examination of ectopic pregnancy is cervical motion tenderness. Cervical motion tenderness. And the cervical motion tenderness is actually a PV examination, per vaginal examination, and we move the cervix, okay, to the right and to the left. If it is positive cervical motion tenderness, then we can suspect two things. We can suspect pelvic inflammatory disease or an ectopic pregnancy. How to differentiate by cervical motion tenderness? Is it pelvic inflammatory disease or ectopic pregnancy? In ectopic pregnancy, cervical motion tenderness, if you move your hand or your finger to the right side and the patient has pain in right side, then it is ectopic. Okay, if you move to right and the patient has a pain in right side, and if you move to left and the patient has a pain in left side, okay, then it is positive ectopic pregnancy cervical motion test. In pelvic inflammatory disease, we have the opposite case. Okay, you move your finger to the right side and the patient has pain in her left side. Okay, so this is about cervical motion tenderness. Do not ever forget this physical examination in ectopic pregnancy. A speculum also is important because we may see gestational sac in cervix, though rare, but we still may see gestational sac in cervix or open os, for example, in a case of miscarriage. Okay, now let's move to the workup of ectopic pregnancy. What laboratory tests we have to do? Okay, first of all, we have to do a pregnancy test. Okay, beta HCG levels. Normally beta HCG levels double every 48 hours, okay? That happens in normal pregnancy. But if we have an increasement of less than 66%, then we have to suspect ectopic pregnancy or miscarriage. Okay, if it is below 66%, okay, because that means we do not have enough trophoblast to secrete beta HCG. Okay, it's important test in ectopic pregnancy, beta HCG. Progesterone levels, okay, and nowadays it is not that reliable, but I just want to mention it. And progesterone levels, the normal range is between 5 and 25, okay. If we have below 5 progesterone, then we have to suspect ectopic or dead pregnancy, ectopic or dead pregnancy below 5. If we have above 25 progesterone, then we suspect a normal pregnancy, okay. Between 5 and 25, by normal I mean a case of neutrality, okay, no ectopic nor normal pregnancy, okay. So this is about progesterone level. So pregnancy test, beta HCG, and then progesterone level, and after that we have to do ultrasound, of course, okay. Ultrasound, we suspect to see gestational sac by transvaginal ultrasound when beta HCG level is 1000, okay, or more. We suspect to see transvaginal ultrasound gestational sac. And to see abdominal ultrasound gestational sac, beta HCG level should exceed, okay, 5000. So 1000 to transvaginal ultrasound, because it gives a more clear view transvaginally, near to the uterus, okay. And above 5000 beta HCG, we suspect to see abdominal ultrasound. If we don't see transvaginal ultrasound gestation sac above 1000 beta HCG, then we have to suspect something wrong, okay. And the same for the 5000 abdominal ultrasound, okay. What do we suspect in ultrasound? First of all, we may see intrauterine pregnancy, okay. If we second thing we can suspect is adnexal masses for ectopic pregnancy, adnexal masses, okay. And the third thing to see is fluid collection, the case of ruptured ectopic pregnancy, okay. But be careful not to judge a pseudosac as a normal pregnancy, okay. Sometimes we have what we call pseudosac, and actually the sac in the center of the uterus and not attached to the wall of the uterus. And to differentiate between pseudosac and normal sac in pregnancy, we have to do what we called ultrasound floating test. We administer a normal saline in the uterus, and if we have a floating, okay, then we have intrauterine trophoblast pregnancy, okay. If there is no floating, then we have intrauterine pregnancy, okay. So the floating of a trophoblast indicates that we have a normal pregnancy, and if there were no trophoblast, then we have an empty sac or pseudosac, okay. The most important diagnostic test of ectopic pregnancy is laparoscopy. Laparoscopy will confirm the presence or not of an ectopic pregnancy, okay. But make sure that we don't use laparoscopy in acute cases of bleeding or abdominal pain, for example, okay. Now let's move to the management of ectopic pregnancy after talking about history of triage, abdominal pain, bleeding, and amenorrhea, physical examination, vital signs, and so on. Now let's move to the management of ectopic pregnancy. We have two cases: hemodynamically unstable patient or hemodynamically stable patients. Okay, in the case of hemodynamically unstable patient, we have to give a blood transfusion and fluid replacement. Okay, we have transfused blood and give fluid replacement to make it hemodynamically stable, and then we go directly to surgery. Two surgeries are done: salpingectomy or salpingectomy. Okay, in salpingectomy we remove the tubes. In salpingectomy we ligate the we cut from both sides around the ectopic sac, okay, and remove it, and we ligate the tubes. That in salpingectomy. If we have a hemodynamically stable patient, we can do conservative or medical management. Okay, the conditions in which we do medical management is below 5,000 beta HCG level. We have to have below 5,000 beta HCG level, no bleeding, no active bleeding, and under 5 millimeter gestational sac. Okay, and patient willing. Patient should be counseled and asked if she want to have medical management. Okay, and of course hemodynamically stable patient is the most important condition. Okay, then after what is the medical management of ectopic pregnancy? We give methotrexate. Okay, methotrexate, an IM injection of methotrexate. Okay, and how to follow up the IM injection of methotrexate? In the next 2 to 3 days, you should expect beta HCG levels to increase. Okay, but after 4 and 7 days, we have to do a beta HCG test, and they should decrease by 10 to 15% if the treatment is successful. So in the first 2 to 3 days, beta HCG levels will increase. At the 4th day, it should decrease, and at the 7th day, it should also decrease by 10 to 15%. Okay, if it decreases by these numbers, then we complete the medical management. If not, we will move to surgery. Okay, and also if the beta HCG levels were below 1,000 and dying and decreasing, then we can do conservative management by following up the patient. Okay, so this is the management of ectopic pregnancy, and this is all about ectopic pregnancy. See you in the next video. Thank you very much.